for having me. My name is Chuang. I'm currently a breast surgeon in New Jersey, and I practice out of Jersey City and Montclair. Obviously, I'm biased. I think breast is the best specialty there is, and I think everybody should be in it. So today I'm just going to go over a little bit background about myself. Then I'm going to talk about general surgery, and then I'm going to talk about breast surgery. And then I'm going to talk about some advice that I can give for students who are interested in going into medical school. So here is my webpage. I am a board certified general surgeon, which means I did 5 years of general surgery residency, and I passed both my written and oral boards to become board certified. You don't need to be board certified to practice, but most physicians in the US are board certified. And here's my webpage. So how did I get here? Here I am, I think probably 8 years old. And then here's a picture that I took during rounds one day during general surgery residency. So I didn't come from anywhere special. I went to a normal public high school in New Jersey. I took all the regular classes, some of the honors and some of the AP classes. I took my SATs. And then I went to Villanova, where I majored in biology and also did a concentration in honors because I wanted to go to medical school. Besides just studying in college, I made sure I had a little bit of fun. Here is a picture of me at the head of the Schuylkill in Philadelphia in one of the races. And I am right here at the back of the boat where I was a coxswain. I actually was an avid runner in high school, and I really wanted to be involved in some kind of sports in college. I did rowing in one of my summer camps, so I wanted to do rowing in college as well. But because I was a short girl who was very skinny back then, they asked if I wanted to be a coxswain, and that's how I became a coxswain. I had no skill prior to this and no training, and I just walked on. But I thought it was a great experience for me to learn about teamwork and leadership, and it really helped me with my confidence. So in rowing, the 8 girls are the muscles and they drive the boat, but they can't see where they're going, and everybody has to move in sync in order to move the boat really swiftly. And that's where the coxswain comes into hand, where they tell all the girls how to move and how to work as a team and how to move the boat swiftly. At first, I was very timid and I wasn't confident with what I was doing. But my stroke seat, which is this girl here, would tell me, you have to be confident with what you're doing. You have to be sure, even if you're wrong, because we can't see anything and we're trusting you. So I thought that being a coxswain in college really prepared me for my future in medicine. While I was applying for medical school, I got a master's in biomedical sciences and also a master's in public health. I was always interested in public health because I thought that if you knew more about public health, you could do more than just being a physician, because being a physician, you can treat one patient and you can only treat as many patients that you can get in contact with. However, if you understand public health and policy, you're able to save more lives. Some examples of public health policies that are in include vaccinations and seatbelts and laws like that that help you save more and more lives. I also did a master's in biomedical sciences. So I was in a very unique program. I wanted the master's of public health, but they allowed me to get another master's and took some medical school classes as well while I got it. So I was able to get both degrees basically for the time and price of one. So my core for one master's counted toward my elective toward the other. So I was able to get both degrees. So it also gave me another shot to see if I really wanted to go to medical school and if I could really handle the academic load that was required of me in medical school. After that, I went to UMD&J, New Jersey Medical School. It's one of the public medical schools in New Jersey. I had an amazing time there. My first and second year were the academics and the didactics, which we took in Newark. And then our third year, we did most of our rotations around Newark. And then fourth year is kind of like where you just put your application in and then you go on interviews and then you have fun and go to happy hour for the rest of the year. This is a picture that we took on match day after we find out where we all end up. And ironically, this picture is still on our medical school website, and they continue to use it after we've been gone for over 10 years. And I continue to be close friends with this group of people. After that, I took my journey to Long Island, where I did 5 years of general surgery residency at Nassau University Medical Center. So when you choose which residency you want to go to, you can go to a big academic program where you see everything, or you can go to a small community program where you see bread and butter stuff, but you get to handle everything as well. So I went to a small community program in Long Island, which was a level 1 trauma center. And we worked really hard. We can do basically anything because you just have to hustle and get things done while you're there. It's a very, very poor population there. A lot of people are illegal immigrants who just needed care. So we were able to provide that care to those patients. And this is a picture from our end of the year graduation. You can see that there are residents in this picture, our surgical coordinators in this picture, there's attendings, there's nurses, there's significant others. We worked really, really hard during residency, but we also had fun together as well. So my goal here is to convince everybody that surgery is the best specialty. So after general surgery, it can last, a surgery residency can last between 5 to 7 years for every person. It differs. I chose the 5-year route, which is 5 years of just working as a surgery resident. If you choose to add research, you can do 1 to 2 years of research, and that's how you can do residency for 5 to 7 years. And after general surgery, you can go out and practice general surgery, which means you take out gallbladders, appendixes, do hernias, do some colon resection. You'll find a really good living being a general surgeon. However, some people try to specialize after general surgery. And there are a lot of places that you can go from general surgery. So the route I took was I went into a breast fellowship, which is a 1-year fellowship after general surgery. If you want to do all of surgical oncology, that takes about 2 years. You can go into cardiothoracic, where you just operate in the heart and chest, and that can be anywhere for 2 to 3 year fellowship. You can do colorectal, where you manage the colon and diseases of the colon and any ostomies and any pathology in the rectal area. And that's a 1-year additional fellowship. A lot of people go into trauma critical care. So you can do them separately and they're 1 year each, or you can do them together and they're 2 years. And therefore there you can handle everything that comes in through the ER and the critical care unit as well. A lot of people want to go into plastic reconstructive. So there's 2 paths that you can go for plastics reconstructive. You can go directly into plastic reconstructive, which is just a 5-year residency, or you can do the 5 years of general surgery and then going into the 3-year plastic reconstructive route. The 5+3 is less and less common. They're trying to do more integrated. For cardiothoracic, you can also do a combined one as well. You can go directly into the cardiothoracic residency. That's a 5-year combined. And there's one more, vascular. I forgot to put vascular on. But vascular, you can also do direct into vascular, or you can do general surgery and do 1 to 2 years of vascular surgery. From general surgery, you can also go into pediatric surgery, which is usually additional 1 to 2 years. You can go into endocrine surgery, where you just operate on the thyroid and the adrenal glands. You can also go into transplant surgery, where you perform liver transplants and kidney transplants. You can also go into MIS, bariatric, which is minimally invasive surgery or bariatric. That is becoming the trend of the future, where we're operating on people with small holes and letting them recover a lot faster. You can also go into hand from general surgery. It's a little bit more rare. Usually people go into hand after plastic surgery or orthopedic surgery, but that is one of the routes that you can go after general surgery. So I have some pictures that I've seen from my 5 years of general surgery that I saw in Long Island. So this was a picture that I saw in my plastic surgery rotation. So this is a woman who was born and had a little horn growing out of her head. and it got larger and larger. We ended up writing a paper up about this. There's probably about like 4 or 5 of these nationally. And it's just a cutaneous form, and we just took it out. But this was an interesting case that we saw on our plastic surgery residency rotation. This is an example of something we usually see in trauma. This was a gentleman who was minding his, and out of nowhere, his grandma says the fork, and here are his. This was a 18-year-old child. He was playing with a carbon dioxide This is another gentleman that we saw in the ER that has a soy sauce bottle that was stuck in his rectum as well. And of course, we were called as general surgeons to remove this object. We ended up taking this patient to the operating room and opening up his colon and removing the object from him. This is another consult that we got from the psych ward. So this is a patient's abdominal film, and he has a psychological problem that causes him to eat things. So here is a lighter fluid thing that he ate. Here is a screw that he ate, and then he ate a bunch of rocks as well. So we had to follow him and make sure that these objects went through his colon and that he defecated everything and didn't cause any obstruction. Luckily, this guy did not need any surgery. This is a mass that I took from somebody's kidney, took off. And in trauma, at a level 1 trauma center, we deal with a lot of gunshot wounds and stab wounds. So a procedure we often will do when we're in trauma is something called an ED thoracotomy, which means that in the ER, we will open up the patient's chest in an attempt to resuscitate the patient and get the heart restarted. This is in Long Island, we deal with a lot of blunt and penetrating trauma. So this was a person who was in a car accident where their heart stopped. And in order to try to save their life, we opened their chest open and performed open cardiac massage on this patient. And this is where we open the left chest. And this is the clamp that we put in to clamp over the aorta. This is a pediatric surgery case. This is a little boy that was born with all of his intestines outside of his belly. So every day, the first day we put this on, his intestines went all the way up to here. And then every day I was responsible for going to see this child in the ICU and massaging his intestines and putting a little tie down. So every day the bowel goes back into his belly. And once it is close, we took him to the OR for permanent closure for him. So I have a really disgusting photo to show. If you guys are afraid of something that is bloody, just turn away for a couple minutes. This is one of our trauma accidents that we got. This was a gentleman who was high on cocaine and intoxicated, who was involved in a car accident with a truck. And this is his mangled extremity that we had to take care of. So that was just a quick bit about my experience as a general surgery resident in Long Island. So after I did 5 years of general surgery, rotating through all the subspecialties, trauma, pediatrics, cardiothoracic, ICU, I decided to go into breast surgical oncology. I went to Mount Sinai West, St. Luke's, and Beth Israel, where I did a 1-year breast surgical oncology fellowship, where I focused on the treatment of benign and malignant disease of the breast. This is a picture of my program director, Susan Bulbul. She's pretty well known nationally, and my co-fellow, Lisa, and I, during our poster presentation at one of the national conventions that we had in Texas a few years ago. So, oh, it's not. This is a video. It's not playing. No. This is a video of me draining a benign cyst from a patient's breast. So a cyst is a collection of fluid, and you can have cysts anywhere in your body. You can have them in your kidney, you can have them in your liver, you can have them in your ovaries, and you can have them in your breast as well. They don't cause anything except for a lot of pain. And this was a video of me draining a 5-centimeter breast abscess, a breast cyst in my office for a patient. This is a 15-centimeter benign mass that I removed from a patient's breast. It's a benign solid growth, but when these masses get really large, we tend to remove it in case we are missing anything. And in addition to benign pathology of the breast, I also treat malignant pathology of the breast, including breast cancer. So again, if you do not like seeing gross pictures, please turn away for a couple of minutes. Here is a picture of a woman with stage 4 breast cancer. She had come into the ER for some weakness, for some abnormal labs, including elevated calcium. And then she was found to have this large fungating mass on her breast. She's had it for about 5 years and never had it taken care of. So I was told to come and get a biopsy of this tissue so we can figure out how to treat this patient. So as a breast surgeon, this is what my average week looks like. So I'll have office hours about 2 days a week. During that time, I'll see new patients, I'll see follow-up patients, and I'll do some procedures in the office like draining cysts, or I'll do biopsies using an ultrasound. I usually spend about an hour with every new patient, getting their history and their family history and working them up. And I'll spend about 15 to 30 minutes with all my follow-up patients. So this coming Monday, I think I have about 13 or 14 patients that I'll be seeing on Monday. So I'll see office patients probably twice a week. And I do have an ultrasound guided biopsy that I need to do this week. And then the other 2 days of the week, I'm usually in the operating room. So as a breast surgeon, we perform 2 major surgeries. We perform mastectomies, which are removal of the entire breast. And we also perform partial mastectomies, also known as lumpectomies, where we remove a small area of the breast and try to rebuild the breast up. So usually I'll have 2 days where I operate and then 2 days where I see patients. And then the last day I'll usually use to catch up on paperwork, make phone calls, and I'll also, if there's any urgent new cancer patients, I'll see them on that last day as well. So here's a picture of me with my fellowship class when we went to a cadaver lab in Houston. We, as a group, breast surgeons, are all very happy with the specialty that we chose. We get to have the best of both worlds. We get to see patients in the office and we get to operate as well. And we also have a great lifestyle because we don't have to take care of any emergencies. Everything can wait till the next day or on Monday. So we're able to be a physician and take care of cancer and also have a great life. So how did I choose breast surgery? So At first, knew I wanted to go to medical school. I really enjoyed being in the sciences. I enjoy helping people. I like knowing why things happen and understanding the concept. I was not somebody who was going to go into business, who can talk to other people. I was very science oriented. So I was going to do either medicine or become a scientist or a researcher or teach math. I have a childhood friend. We both wanted to go to medical school and we wanted to become pediatricians because we love working with kids. When I went to medical school and did my pediatric rotation, I realized that I like working with kids. I just don't like working with sick kids, and I don't like talking to the parents of the sick kids. So I ended up not going to pediatric, even though at first I wanted to go into pediatrics. During my first year of medical school, I was able to get a scholarship to an anesthesia program, which allowed me as a first year medical student to go into the operating room. Usually you're not allowed to go into the operating room until you're a third year medical student, but because I was in this program, I was able to go into the operating room. And I loved anesthesia. And the hours were going by so quickly. It didn't matter how early I had to get up in the morning or how late, how I had to stay. I loved being in there and I loved procedures. So I thought I wanted to do anesthesia. I did a bunch of anesthesia reports. I did a bunch of anesthesia research. I even went to the National Anesthesia Meeting. When I did my third year rotation, where I did my general surgery rotation, I realized my true love was always general surgery and never anesthesia. Because of anesthesia, I was able to go to the OR as a first year student, but I found myself always peeking over the curtain between anesthesia and surgery and always wondering what the surgery side was doing. I realized if I did general surgery, I would never have to peek over the curtain because I was on the side of the curtain. As a young woman in medicine, there were a lot of people who strongly discouraged me to do surgery. They said that you can't have a life, you're going to work really hard. Nobody will ever want to date or marry a surgeon. You can't have kids, blah, blah, blah. A lot of people discouraged me from having it. And, I was worried as well. So between my third and fourth year, I did a 3-month sub internship where I did surgery 3 months in a row with no break. And I told myself, if I could handle those 3 months and be happy, then I'm going to apply for general surgery. Otherwise, I was going to apply into anesthesia because that was a better lifestyle for women. Those 3 months, I was so happy and I was tired, but it was a good tiredness. So then I decided, okay, I'm going to go for it. I'm going to go into general surgery, even though people told me not to, but it was something that I really liked. And even though it was 5 years, most of the other specialties end up being like 4 or 5 years anyway. Like anesthesia is 4 years. If you do any subspecialty in medicine, that becomes 6 years. So I was like, if I'm going to do something, I want to do something that I love. So that's how I got into general surgery. And then while I was in general surgery, I wasn't sure which aspect of general surgery I wanted to specialize in. I could just be a generalist and just do general surgery. But because we were in an underserved area, we had a mandatory breast clinic every week where we gave free mammograms, free screenings, and free treatment for breast cancer for all the women in the area. I ended up loving that clinic because it was a multidisciplinary aspect. We worked with the radiation oncologist, the medical oncologist, the radiologist, and together we treated the women with breast cancer. And in most specialties of surgery, you operate on the patient, they do well, and you never see them again. But in breasts, you operate on them, they do well, and then you continue to see them for 5 to 10 years on. So I like that we had the best of both worlds where you could operate on somebody and you had some continuity of care, but it wasn't too much continuity of care like you see them every month, but you saw them every 3 to 6 months or every year, and I enjoyed that aspect. So some advice that I can give for people who want to go into medicine. I really, really strongly suggest that you shadow different doctors and make sure this is what you want to do. Because if it is something you want to do, it is a long path, but you'll be much happier if it is something you want to do. If you know early on that it's not something that you want, don't go down that path. So I shadowed a cardiologist. I got to see some procedures that he wanted to do. I got to see him in the office, got to see him in the cath lab, and I really enjoyed both aspects of it. And he wanted me to make sure that I wanted to do it. On some medical school application committees, if you don't have a family member in medicine, they'll usually ask you why you want to do it. And they'll usually want you to do some shadowing because they want to make sure that you do want to go down this course. when you go to college, it doesn't really matter what you major in. One of my best friends majored in Arabic, another one international relations, a bunch of people were engineers. We have a musician in my class. One of my seniors played the clarinet at Juilliard. So you can do whatever major you want. It actually makes you stronger if you're not a bio major, but just make sure you take all your pre-med courses just in case. Make sure you do well in all your courses and you do well on your MCATs. As somebody who's been part of the admissions committee, they look at those scores and they'll give you a score based upon that. If your pre-med courses aren't good, or if your college and undergrad scores aren't great, it might be better for you to do a post-bac program to strengthen up your resume. Also, try to participate in extracurricular activities. I did rowing. You know, don't do everything that is medicine, but do some medicine ones. They want to find somebody who's normal and who wants to have fun. Be persistent. If this is something you want, keep on trying. Figure out ways how to make your application better. And also be professional. I know a lot of people reach out to some of my friends and then they don't want to help them. Everybody talks. Just remember that. When I was giving out when I was giving out tours for medical students, if somebody was rude on the tour, the admissions committee knew about it. If somebody was rude to the secretary, the admissions committee knew about it, and they would not have a chance at our medical school. So it doesn't hurt to be nice and to be kind and to be a well-balanced person. And to show you that doctors do have fun, these are some of my friends. We all went to Miami Beach, and then these are all physicians. Most of us who went were all physicians. The one who took the picture is a physician as well. I'm a surgeon, there's a pediatrician, there's a GI doctor, there's a pain doctor, there's a regional anesthesiologist, and there's 2 other anesthesiologists in this picture. And we're just normal people who happen to be physicians as well. And I think that is it. And good luck to everybody who wants to join this wonderful field. Do you guys have any questions for me?
There was a question in the chat earlier. They asked what a biopsy was.
Oh, a biopsy is where you take a sample of the tissue.
There are more questions coming in through the chat. Can you access the chat by any chance?
Okay. What is a biopsy? Biopsy is a tissue sample. How do you deal with burnout during medical school? Well, that's why I want to make sure that everybody who goes into medical school really wants it. Burnout is really hard. So for me, what was helpful with it was that I went to a state school that was close to home. So I had a lot of family support. My parents would bring me food, or I would come home during exams where I was really stressed out. I also had a really good social system at school where we worked together with my classmates, where we worked out together, studied together, ate together. So that was really good. Breast surgery, we don't just remove tumors, we also remove cysts as well. We remove lymph nodes because sometimes breast cancer can spread to lymph nodes as well. So we do that. We do all the removing part. The reconstruction part is done by the plastic surgeon. My favorite part of the day is always being in the operating room. It's never paperwork. And I really don't like being in the office, but you have to be in the office to get your patients for the operating room. But by far, operating room days are my favorite days. Some of the hardest cases that I've done as a breast surgeon, one of the complications that we can have when we remove a lymph node underneath the arm is experiencing lymphedema, which is chronic permanent swelling of the arm. So I had a patient once who already had chronic permanent swelling of her left arm from a cancer, and then they wanted me to take out a big node from her right arm as well. And she had a high chance that she would have that chronic swelling in that arm. And she was also on a bunch of medications that caused her to bleed a lot, and she was old and she had an aggressive tumor. So I thought that was one of the hardest cases for me to do because I had to be so delicate because I didn't want her to bleed, but I also didn't want her to get that chronic swelling in her arm. How would you say that you balance your time between medicine and public health? Do you do research in public health? How do you integrate your medicine? So for me, having a master's in public health, I have a master's in public health in epidemiology, which helps me understand how to run all the statistical analysis that are required for data analysis to help me write papers. So for me, I use it all the time when I'm reading my journal articles or when I'm writing papers and I'm looking at the statistical analysis. I think also public health also helps for breast cancer because you want to spread awareness and spread information about it. So I'm constantly trying to give talks to family med doctors and everything like that to let them know what the new and up-to-date information and treatment for breast cancer is. When patients are very challenging, sometimes I just step back, take a deep breath, and I don't blame them. I said they might be dealing with a hardship that I don't understand, and they're doing this because this is all they know. I try not to blame the patient, and I try to rationalize it. I try not to personalize everything because that can get very upsetting, but I try to understand where the patient might be coming from. I do have some patients that can be very challenging, but I just step back, take a deep breath, talk to my husband sometimes, or talk to my colleagues. That helps. How do you deal with racism, sexism, especially wage gap? It's pretty tough to deal with the racism, sexism. People had told me that a woman's place is not in the OR. One of our senior attendings always tried to make the female residents cry, but the more they did it to me, the more I wanted to prove that they were wrong. And after the 5 years, me and the other female resident got a lot of praise from that attending who tried to push us down, but he said that he was trying to make us stronger, supposedly. But for when people try to challenge me, I just say, I'll do better and I'll show you how to do it well. Is there another, for breast cancer, mammogram is unfortunately the gold standard. What we can add on top of mammogram is ultrasound and MRI as well, but mammogram is the gold standard. If patients complain about pain from the mammogram machine, sometimes I'll ask patients to take Tylenol or ibuprofen prior to the mammogram. That will help decrease the pain. And I often ask them to get a senior tech that will help relieve the pain as well. I closely work with a physician assistant. People in medicine tend to have nurse practitioners, and people in surgery tend to have physician assistants because physician assistants can go to the operating room. So my group has a physician assistant. That's who I worked with. For breast cancer, there aren't any labs that like colon cancer that can detect anything, but we do have markers that the medical oncologists will run to see if they're up or not. And if they are up, they will run a CT PET to see if there's any distant metastasis. When I first entered surgery, did you feel a bit nervous? Absolutely, I felt nervous. I felt like I had imposter syndrome. I thought I didn't belong there or anything like that. But I had great mentors and great seniors and great colleagues. And I just said, this is what I want. And every day I just got stronger and stronger and got more and more confidence. But every time you go into somewhere new, you drop back down again. Like when I started fellowship, I felt like nervous and I felt like I didn't have confidence. When I first started practicing by myself, it dropped as well. But as time goes by, you'll know that what you learned is really great and you'll do well. How good is your work? My work-life balance is pretty good. I work 4 days a week and I have basically 1 day off and I have all my weekends off. So on my weekends, my husband's also in medicine and is also a surgeon. So I tell him he's only allowed to take 1 weekend call. And after that, weekends are family time. So my husband and my daughter and I, on the weekends, we will go out to dinner and lunch and we will explore an area. So we've been going to the beach every weekend and I'm adamant that we spend family time. And we try to have dinner every single day as well. And we will wait for each other. I try to instill that in my family. I went to Rutgers for graduate school. Mammogram, MRI, and X-ray. A mammogram is like an X-ray. They use the X-ray for the mammogram. MRI is a magnetic rays and it's dynamic, so it's functional. They will give the patient contrast to see how the contrast reacts in the breast. So it's a functional exam versus a mammogram is a static exam. Can mammograms cause breast cancer? Very, very rare. The amount of radiation that you get from a mammogram is less than how much you get every day in the sun. So no. I'm sorry, that was really fast. What are the biomarkers that are being tested in the lab to help detect cancers? There is no specific biomarker that we have for breast cancer, but sometimes they'll look at CA levels or CA 125 levels, which are just cancer markers, but there's no specific biomarker for breast cancer in the blood. CA 125, correct. But CA 125 is better for ovarian cancer. No, it's hard to change. It's hard to go from internal medicine to general surgery. It's easier to go from general surgery into internal medicine. You can switch. There are people who switch, but it's easier to go to the medicine. It's harder to get into general surgery. My Instagram name is there. If you guys have any questions, feel free to message me. I'll be happy to answer any questions that you guys have. Good luck, everybody. And I wish you guys luck. We'll all be colleagues one day. I don't have an MD, PhD, but some people who are more intellectual who want to do into research like to do MD, PhD. They take about 7 years, I think. But you have to ask somebody else. I didn't do MD, PhD. I just did a regular MD.
Okay, thank you so much for coming. I learned a lot. Thank you so much. I'm pretty sure everyone else had a great time. I really found your presentation very interesting as well. So yeah, thank you for coming.
It's my pleasure.
I think that...
It was my pleasure. Good luck with everybody.